Good afternoon, Excellencies, ladies and gentlemen. We seem to be in a very tight room. We do apologize for that. We couldn't get a bigger room, but I'm sure you'll not feel the time flying. Ladies and gentlemen, it is really wonderful to see you here today. My name is Magda Robalo. I'm the co-chair of the UHC 2030 Steering Committee. The UHC Steering Committee is, the UHC 2030 is the leading global multi-stakeholder platform for accelerating progress towards universal health coverage. Our members include countries, civil society, the private sector, foundations, and international organizations. And as such, we drive discussions on how we can progress towards the goal of achieving universal health coverage. Universal health coverage means everyone, everywhere, has access to the highest quality of health services without financial hardship. So if you combine all those elements, you can see that millions of people still don't have access to the high quality health services they need when they need it, where they live, without financial hardship. Service coverage has been increasing worldwide. A main challenge remains to achieve universal health coverage is protecting people from financial hardship and bringing down financial barriers to accessing services. Worldwide, 2 billion people face financial hardship due to out-of-pocket payments on health, including 344 million people living in extreme poverty. Financial protection is not only stagnating, it's actually deteriorating. This means that the more people access services, the more they are impoverished. This means people must make hard choices between paying for food, paying for education for their children, or they pay for treatment they need. And as such, financial hardship is one of the drivers that widen health inequalities and is closely linked with gender disparities in health. This is because socioeconomic factors, including poverty and limited employment opportunities, disproportionately affect women's access to essential medicines and services. These barriers worsen health outcomes for women and contribute to broader cycles of inequality that hinder economic and social development. Evidence suggests that addressing these barriers through gender-responsive health systems and health financing policies is crucial for breaking the cycle. We therefore need financial protection measures that consider the specific needs of women and people of all genders to achieve equitable access to health care and to improve health outcomes. It is unacceptable that women and girls face higher risk of infections, diseases, and preventable deaths, and that they suffer from conditions that could have been avoided or treated if their health concerns were adequately prioritized. I'm therefore so glad to be here with you today to discuss how we can address financial hardship, to tackle these inequities that arise from the unequal distribution of power and resources in our societies. Throughout the discussion, we will hear from several UHC champions who will share their personal insights and recommendations on how we should address financial hardship to advance gender equality and universal health coverage. To start, it is my great pleasure to invite Dr. Ethel Maciel to the podium. Dr. Ethel Maciel is the Secretary for Health and Environment Surveillance of the Brazilian Ministry of Health. Honorable Secretary, the floor is yours.
Thank you, Magda. It's a pleasure to be here. Sorry. And in the name of the Brazilian government, I would like to say that although we have our own experience, every country should find your own universal health coverage, universal health system, because we are very different in some ways. Brazil has a longer history of slavery, and this has a past history of inequality, not only gender, but race and ethnicity. So in our policy, this is the center of our health service right now with this new government. It's not always like this, but we have more than 30 years that we building this universal health system in a very unequal country that reminds with this heritage of the slavers. And what we are doing right now is to putting the gender and race ethnicity in the center of all policies in Brazil. We have for the first time a woman as a Minister of Health. So imagine that. In a country with this long history, is the first time that we have a woman leading this minister, the Minister of Health. That is in Brazil is the second budget from the country. And in my position as a Secretary of Health and Environment Surveillance in Brazil, is the first time that we have a woman too. So we have the first. The first women leading this area in Brazil, and this as women gender equality is in the center of all agenda in the health right now. We are in the G20 presidency right now, and we put in the G20 declaration with climate change, One Health, and we focus in AMR, the policy of equity. And when we proposed that in the beginning of this year, when we started the presidency of Brazil, we thought that it's a very easy to agree. Who will be against to have an equal world that you, usually in all countries, when we have the impact of climate change, children and women will be the most that are suffering from this impact. And probably no one will be against this policy. But it's very hard to make this agreement. But we are working with all the countries to have this finished in the end of October in this declaration of G20 for the first time to put equity and climate change and One Health approach with this agenda of gender and race balance in this policy. So Brazil has also a very important cash transfer program that was created 20 years ago, which you call Bolsa Família program. But it's not enough. What we are seeing in the last 20 years, 10 years ago, this year make 10 years, that we have a policy for education to have some reserve from people that are race and ethnicity with indigenous and African descendant. And with 10 years of this policy, we are seeing for the first time some social mobility that was very hard on 20 years ago. So what we want to say to all of you, that this made a difference. have this political will, the commitment with the gender equality and race. It's very important to the country, and we should asking for this, and very important, vote for this. And we are facing in a very complicated world with a lot of conflict, war, and we are talking in these 2 days that we are 1 day. I'm with jet lag, so it's 1 day, 2 days. But in this day that we are here, we are talking with the pandemic agreement that we didn't agree yet, but there's hope. And with this climate change that a lot of countries are facing, and Brazil include, we are not until now have a lot of impact of climate. We are used to say that climate was a very friend of Brazil, but not anymore. And we are facing this climate change impact in a way that we didn't see in the past. So we have to change the way that our health system was building, because they are not building to think in this climate change impact. So right now we are rethink the way that we building this healthcare system in Brazil. But to close my intervention here, and I'm open to talk with you. And Brazil is committed with this very important speech for the world. We need to build trust. We have to make at least less unequal, because there is no trust if there's such a hierarchy between us. If we are putting the highlight in our difference in what we have in common. So saying that, Magda, I would like to say that Brazil is open to collaborate with the other country to build this trust and to have a world that we can have, that we are proud to live in. So thank you very much.
Thank you so much, Dr. Ethel Maciel, for reminding us that it is not just your socioeconomic status that matters. Your race matters, your ethnicity matters, and the lenses that we need to use to push for gender equity, to remove financial barriers, has to be multiple, so that we avoid leaving people behind or pushing people behind. Thank you for that reminder, and thank you for letting us know that Brazil is willing to work towards peace around the world. That's very important. Thank you. I will now move to the first panel, and we have the pleasure of having with us Chedu Moyo, Youth Representative to the Global Financing Facility Investors Group and Executive Director of the Lunia Center for Youth, coming straight from Zimbabwe, and Luc Laviolette, the Head of Secretariat from the Global Financing Facility. Luc and Chedu will share insights on the current context and opportunities with regards to addressing financial hardship and gender disparities in health. So I will start with Chedu Moyo. You are the founder and executive director at Lunia Center for Youth, a hub where young people can collaboratively drive change in the field of climate change and public health while mainstreaming gender equality. Can you share your experience of how gender bias affects health outcomes of women?
Okay. Thank you so much, Magda. So for that question, I want to give a visual representation. So I want you to imagine a girl named Princess. She's 15 and she's from Zimbabwe. She's eager to finish her education. She has heard about contraception, but her access is limited, and actually it's severely limited. And the nearest clinic is kilometers away, and they often lack supplies. Additionally, the clinic where she has to go to requires parental access, and she's afraid if she asks her parents, they are strict, they will shout at her. And despite her efforts to avoid pregnancy and continue with the education, Princess finds herself pregnant. And now her community has stigma around teenage pregnancies. And so instead of getting support, she is faced with judgment from her peers and community members. Now, because she's pregnant, many blame her for her situation, ignoring the circumstances that she has faced. And during her pregnancy, Sihle struggles to find prenatal vitamins. She also struggles to get access to adequate nutrition or any other health services that a pregnant woman can acquire. Remember, she doesn't even have the support from the family. Now, she even wishes she can abort, but she can't abort because the law is restrictive. It does not allow her to abort. So now she lives in a community that is challenged also by climate change, like we have seen how climate change is affecting communities. So now this means that she has to survive on one meal, maybe hard maize porridge per day. And she just has to rely on that. And as she navigates her pregnancy, Sihle becomes sick, and the community continues to shame her, saying all sorts of things. And this lack of support, it leaves her feeling isolated and overwhelmed. She can't even go to church or even attend any cultural events because of now she's an outcast and the stigma around teenage pregnancy and how she actually got pregnant. Eventually, Sihle has a home delivery, and her child continues to face the challenges that she faces: lack of access to healthcare, poor nutrition, and the child is malnutritioned. Now, the story of Sihle or Princess is not a folktale. It's a reality that many adolescent girls and young women go through every day. In countries like Zimbabwe, where about 25% of girls below the age of 25 get pregnant, this is the reality, because access to healthcare is very costly, and the other, even access to information and support on its own. So I think, Magda, this presentation is a reality of the many adolescent girls that we see out there. And if you go to the news today, you realize that a lot of girls are dropping out of school. And as soon as they've dropped out of school, this means that their ability to support themselves economically has failed. But also the ability to be supported by family or even their health centers, it has failed, which I think is an important conversation that we need to have as UHC 2030. Thank you so much. I'll stop here for now.
Thank you for Chedu for illustrating a very harsh reality through the history of Princess. Let me now turn to Luke. Luke, as I said, is the head of Secretariat for the Global Financing Facility for Women, Children, and Adolescents. Thank you for co-hosting this event with us. The GFF's mission is to fight poverty and inequity by advancing the health and rights of women, children, and adolescents. Why is it that women, children, and adolescents particularly vulnerable to bias in health? And how is your institution working to reduce the gender gap? Look.
Thanks, Magda, for the question. I also want to thank Chedu because she's done a much better job of answering the first part of the question than I possibly could. We know that that women and girls in many countries have lower access to education. They have special needs, first of all. They often have challenges of access to financing for their work and also for their needs, lower decision making in the households, in addition to their domestic responsibilities. I won't go through all of those details because I think Chedu illustrated that really very well. Maybe a few words on how we work, to confront those barriers and support women, children, adolescents, and in this with around these challenges. So, as you mentioned, you outlined the mission of the GFF very well. Maybe 2 words on how we work, because it'll explain then the rest of what I want to explain. So we're first and foremost a country-driven model. We follow country priorities. We engage with 36 countries, the poorest, highest burden countries in terms of the needs of women, children, and adolescents. And we join them in their journey where they're at, and then work with them on the priorities that they identify through an investment case that is always financed partly by us and largely by the World Bank. So we're part of the World Bank financing, and then others crowd in the funding around that. So there's a lot of work that happens around the design so first at the informing policy stage, and specifically on gender, we've been in existence for 9 years, and in the initial years learned that it really was, this is going to be very obvious, but it was a lesson, that it really is not enough to just say we focus on women, children, and adolescents. When we work within a UHC framework and within health insurance schemes that are developing in many countries, we need to take a very deliberate approach to the analysis that we do to inform policy, to identify the challenges. So we've created a function within our group that is looking very specifically at the barriers that women especially, but also children face in accessing the services. So that informs the policy. So evidence around benefits packages, but also how access is determined, into the health insurance schemes. So that's sort of the informing policy area. The second area is around design and delivery. And so there, having gender-informed data in a regular basis, we find is quite powerful. We have we've now developed a function where we support countries in having data on a 6-monthly basis on how the programs are working, and we put a specific focus on the needs, the barriers that had been identified early on in the design that specifically relate to access and to quality for women. We've also been paying a lot of attention and acting on supporting countries in developing female leaders within the systems, because we know that the evidence shows that translates into designs of programs that are much more gender appropriate. And when it's one thing to look at health system human resources and, on average, generally more female than male. You look at where women are in the hierarchy, and we all know the answer, right? And so then to start working through the dialogue that's led through the World Bank at pretty high levels in the country and start to address that is really interesting. It was interesting to hear that Brazil is just now have a female health minister. So that's another area. And then working on legal reforms, a range of legal reforms, and again, using the ability to work through the World Bank, where budgetary support is linked to these legal reforms. So if there's barriers around specific laws, as we heard in Zimbabwe, we're able to support that. And then on the delivery side, there's some very specific, this starts to get into the nuts and bolts, but I've learned over the years that with health insurance and with universal health coverage, the nuts and bolts really matter. And so looking at, the details of not just the interventions in the benefits package, but the quality of delivery of those and having data around it. It's not enough to just look at whether A and C is part of the package, but how is that first visit going? When does it happen? How are the community health workers doing, et cetera, et cetera. So being able to work with countries to impact that. And then the third area is around accountability for delivery, and we work with civil society partners in country And perhaps the biggest contribution we make, at least that's what we hear from them, is that the data that I was talking about earlier becomes available and they can use that. They're involved in the design. We have examples of countries where, particularly around programs for adolescent girls, that frankly, often ministry officials are not the best to design those, working with civil society and the girls themselves to provide a platform basically for them to design their own programs, but then have data on how they're doing. So I'll stop there for now.
Thank you. Actually, you went ahead and you even answered the next question I was going to ask you, but you generated another question about gender-driven data. We complain that we don't have enough data to assess the situation of women, adolescents, and girls from the gender perspective. But I also think we collect data we don't use, and then we have data we don't need. And this mismatch, I would like to hear from these 36 countries, how do you collect the data you need in order to understand how much progress you're making? I'll come back to you on that. Chidu, my final question to you. Taking into consideration what you described and what Luke also presented to us, what are your calls to action for us to address the challenge and close the gap?
Okay, thank you so much, Magda. I think the one most important thing is to really improve access to healthcare. And by improving access to healthcare, we mean that we need to strengthen health clinics to provide all the health services. We don't need the health services to be maybe for those that can afford only. We need the health services to be affordable at any point of where anyone can access health. This is the clinics, because if we want to achieve universal health coverage by 2030, we have to achieve at least primary health care. And we can't talk about UHC when we haven't talked about primary health care. So we need the clinic, the first line of the clinics where these young girls, these women go to have adequate health services. And the second thing, we are talking about the climate challenges. In the global south, how climate change has changed people's lives, it has translated food systems, which are their sources of nutrition. We're talking about the fishing is no longer there. We're talking about the environment can no longer support agriculture. So the conversation that we should be having now is how do we support these women, maybe who are having babies, these children, to still have adequate nutrition, even when the climate change is doing what it's doing in the community. So maybe we need to initiate programs that offer, nutrition assistance. And I think the other important thing is the issue of mental health, to say the communities are built differently. There's societal issues, cultural, religious, maybe that look at pregnancy differently. We have maybe these young girls that go through postpartum depression. Some will be just going through maybe what they are going through because pregnancy and childbirth and raising children is also a different situation. But we need the mental health services, even the support within communities, so that these women can have a safe space and they can continue to be normal and feel supported in the communities. Because now we have situations maybe where you find these young girls, they end up maybe throwing children in the toilet or doing something that's really not okay because they don't have the mental health support. And the other most important thing that I think Luke touched about the legal reforms, we have a lot of restrictive policies. And what these policies do is they policy not just their policies written in paper, but how they are also implemented on the ground and how they affect the women, the children. At the end of the day, it becomes the age of consent, the no to abortion laws, and also other laws that are really, really, really not okay. I think it's also very important for us, because we are the lawmakers, we are the policy makers at the end of the day, and we inform the policies to challenge these restrictive policies so that they are very comfortable and they are talking to the women and the children. And also I think we still need to unlock resources for comprehensive sexuality education. Why? Because it's some of the challenges that are faced are avoidable if there is enough information, if there is comprehensive sexuality education to especially the young girls. So if we have enough strong health literacy programs for these young women, I think it's going to make a big difference. And of course, education, we don't have to, I know there are some communities that still say girls can't go to school or girls can go to school only to this level. We still need to support women to go to school because their economic status is a big determinant of their health outcomes. So if they are not supported in that way, then and we don't have any equality in terms of their access to education, we are still going to be faced with these preventable challenges, because at the end of the day, all these challenges, the health challenges that women, adolescent girls, and everyone else faces, they are preventable. We all need to just act and do something about it. Thank you so much, Magda. I think I'll stop here for now.
Thank you. Thank you so much. Two important things. She said these challenges are preventable, but the way she articulated education, climate, economic opportunities, laws and policies sends us to the importance of a whole of society, a whole of government action. This is not a problem of the health sector. Will not be able to sort this out alone, and we really need to work across governments to be able to do something about it. Quickly moving to look, before coming, I will come now to those who make the laws, the policies, and then to have a discussion to see how can we address the issues that were raised by Tiju. Look, quickly, how...
So yeah, quickly on your question on data. So first, should be obvious, but to repeat that we support countries in collecting data and analyzing their data. We jump in as needed, but it's really driven by the countries. A number of different sort of types of data, I would say. And to your point, it starts with the priorities that are identified in the investment case, and then the subsequent financing around it, and what data needs are there to actually support the implementation, and then unfolding from that, focusing on, in terms of service delivery, starting with the routine data systems, which are increasingly strong in the countries we work with, and tailoring as needed, for the analysis. But we found that it was really useful to add a very specific gender layer, if you want, on this, and also to accelerate the use of data. So as needed, so at the very least, regular 6-monthly analysis of the HMIS data, but at times extra surveys as needed on preparedness of facilities, on specific gender dimensions of availability of 24/7 delivery facilities, trained female providers, like a regular assessment of how women-friendly are these facilities, privacy for women, etc. So that on the service delivery, also access. We did 2 assessments that are quite telling in neighboring countries, Côte d'Ivoire and Ghana, on women and children's access to the health insurance scheme. Côte d'Ivoire, severe challenges of access related to very practical issues, like they need to come in person with all the children, they need ID papers. We know that that's a challenge, right? So you see lower rates of enrollment for women, and especially for poor households. Ghana, opposite, high rates of enrollment, but they drop out after 1 or 2 pregnancies, and that's because of the recurring user fees, or the out-of-pocket payments, I should say, that are a reality. And so then this informs the investments. The actions are taken accordingly. And then just very briefly looking at making sure that we first make good use of all the available sources of data. So countries that we work with increasingly have social registries as part of their social protection program. So let's not repeat that. And we see countries sometimes repeating this, right? The targeting mechanisms in health insurance, use your social registry, and let's strengthen that. And then strengthening civil registration and vital statistics systems. And we find there's a very rapid payback, if you want, or return on the investment of birth registration, so that access, again, is easier. These are just examples of how, first and foremost, what are the needs based on the priorities, and then what's already existing, and how can we collectively best use the data, including sharing with civil society.
Thank you. Thank you. I take the point on health insurance schemes. We heard from Brazil how Bolsa Familia helped, and 20 years down the line, they are seeing, reaping the benefits of how people could be moving the socioeconomic ladder because they benefited 20 years ago from that support to bring up the family. So moving now, thank you, Luke and Teju, for those very helpful insights. Moving now to Dr. Leah Tadesse, Gebre Medem, Gisela Scaglia, and Dr. Adepeju Adeniran and Taimur Khan Jagra, who will be telling us a little bit about how do we go about policies, laws, in order to create the framework, the environment that will allow people to have access to better healthcare without financial hardship, and then addressing the gender barriers that they face. So let me start with Dr. Leah. Dr. Leah Tadesse Gebremetim is currently the Executive Director of the Harvard Ministerial Leadership Program and a former Minister of Health of Ethiopia. I would like Dr. Leah to ask you, and the question is similar to your other panel members. I know Ethiopia has had an innovative program to provide women with free family planning services from 15 years ago or so. Can you share some insights on how Ethiopia was able to make it happen to prevent princess situation in Zimbabwe?
Thank you very much, Magda, and good afternoon, everyone. Indeed, access to family planning and reproductive health is a key issue we look at in looking at gender inequalities and universal health coverage. And this challenge was really huge in terms of our country. When you go back some 20 years, that's when we actually had it in our constitution, 1995, to explicitly putting access to family planning as one of the women's rights. But of course, it's one step, but having it in a constitution does not magically change the situation. But during around that time, we actually had as low as 8% only of contraceptive prevalence rate. And a very high maternal mortality, of course, related to that and other causes. So the interventions that were done are multifaceted. Of course, it's about the service delivery, the exemption of the services, and commodity issues, which I will try to explain. So in terms of the service delivery approach, our country is largely, like many countries, largely rural and formal sector. And for such a community, making services, basic services, accessible was a big challenge that had to be tackled. So that's when the community health extension program at the community level was started testing it at a small scale around now almost 18 years ago, which by training female health extension workers, these are trained after finishing high school, they are selected from their communities to be deployed in that community after 1 year of training of package of services. And one of the key services was, of course, the family planning. And it did not stop on just providing or promoting, but they provide the services, including depots and including implant insertions, so that the mixed methods were expanded. And it was intentionally, these community health workers, intentionally they were made female workers, except a few exceptions, almost 99% across the board were female, because most of the cases, the issues that they were handling were in the families, was issues about maternal reproductive health, child health issues, family health issues, for which it is mostly the women in the households that they were targeting. And culturally, it was more accessible that the woman health extension worker would go house to talk to the mothers rather than the male extension workers, and among many reasons, of course. So this was really critical in terms of expanding the access dramatically. But of course, unless the commodities are there, the provision cannot happen. So commodities were coming in also fragmented way through different support of donors, but around 2007, there was a shift that was done. One was to remove tax levy from commodities for family planning. And then, again, because it was coming in fragmented way and not enough, the government decided to put a line budget item for family planning from government sources, which was a small component, but it was the decision. It made it sent a message, and then adding on it, pulling the resources from different donors to that, combining that, and then procuring the needed commodities. And this was also shifted to the government procurement system, which included national distribution mechanisms. So this really expanded the access in terms of availing the commodities to the health, up to the health post level. So combining this, it was decided to be a free service because of those efforts. Already the facilities are paid by government for the workers, and the commodity has been availed this way. So it continued. Of course, this was not only done through government outlets, because through social marketing as well. The NGO or private sector were also engaged in this process, where the commodity was provided for free for them, so they would only charge a little bit for the services they provide. So this really expanded the access beyond the public sector. And this, when you look at coming many years later, in 2019, the contraceptive prevalence has increased to up to 41%. And the fertility rate, which was around 7 when we started around the early 90s, it is down up to close to 4 now. So which is a significant progress, and also, of course, impacting the reduction of maternal mortality. And maybe to end, but this to continue this requires really extensive efforts. And recently, during my role as minister, we had, as we all know, development assistance was declining, and the amount that the government was putting, although it was increasing, it was not really meeting that part. So we were at risk of commodity shortage, and we are not yet at a time where we can move it to other systems like the insurance, or it had to stay exempted. So we tried to really negotiate with the Ministry of Finance and donors to bring new funds, additional funds that can be matched, and the government putting new money and donors putting new money. And this is meant so that progressively with domestic financing, the government can take over the commodities. And this was able to raise around 14 million USD for 1 year to meet this gap. And it was a 3-year agreement that we signed, a compact with the donor. So this was meant to maintain that exempted service as we move along.
Thank you for describing how you did go about reducing the number of children per woman from 7 to 4 in about 20 years. Gisela, you are currently the vice governor of the province of Santa Fe in Argentina, and you are a former member of parliament of Argentina for 8 years. You are also the Unite chapter chair for Latin America and the Caribbean. You have worked across different levels of law and policy making, and in these roles, you represented women and people affected by gender discrimination. Could you tell us what are the challenges you have met personally in being heard? Your neighbor, Brazil, it's only now they have had a female minister of health. So what has been your experience?
Thank you, Magda. Good afternoon, everyone. Yes, I want to begin with an example on a story, real story of Argentina, because last year, for example, Julia, 5 months pregnant, went to the hospital twice in severe pain. And the first time she was sent home dismissed as colic. Days later, she returned to the hospital to learn her baby had died. And day after the surgery, she died also. She passed away. So this challenge and this story are common in our countries and in Brazil and probably all around the world. And all around the world, women face a lot of obstacles in making our voice heard. This is the reality of our countries. And this challenge becomes even tougher when we are talking about gender inequality and its discrimination. I have experienced two main challenges. The first one, deep-rooted biases, and the second, the lack of data-driven policies. Systemic biases exist not just in legal and policy-making circles, but in nearly every area of our health system. In Latin America, for example, women are often approached without considering the unique challenges we face. Our health system has historically been designed with a male perspective. This is the reality. We have a male perspective in our health systems. In Argentina, it's not uncommon for women, and I believe in Brazil it's the same, to wait ages for appointments to do their genome checkups, because we don't have enough machines or doctors or professionals available in public hospitals. This means that our specific needs, like importance of regular checkups, are often overlooked. And the same happens when it comes to care protocols, for example, in ensuring rights are respected during childbirth. The high and rising rate of cesarean section in my country, where approximately 50% of births are C-sections, compared to the WHO recommendation of around the 10%, reflects just now how much we still need to focus on respectful, woman-centered childbirth practices. It is crucial for us to gather accurate and complete information to shape public policies that genuinely create positive change for women. By leveraging technology and data, we can better understand the specific challenges women face and develop inclusive and effective policies. Julia's case, happening all over the world, must not only call our attention but spur us to action. We can no longer afford to ignore these issues. It is a matter of life or death. Every woman has the right to dignity, respect, and adequate health care. And this happened to us, and we have to solve in this panel, but in the actual life and in our responsibilities. Thank you.
Thank you for, again, bringing that very sad reality that's, be it Argentina, be it Guinea-Bissau, where I come from, we see on a daily basis. Let me go back to Dr. Leah. You have been Minister of Health, and you were telling us that at some point the government removed the tax levy from contraceptives so that they become more affordable. How do a policymaker like Minister of Health manage to influence governments in order to improve the gender responsiveness of the health system? What are the tactics and strategies that you use in order to be heard and direct the health systems to respond to the needs of women, adolescents, and girls?
Thank you. Indeed, when we are talking about influencing policymakers, the first thing would be for our sector itself to be clear about what should be done and have the gender lens in everything we do, in how we design our strategies, and also have the evidence that shows the investment case. So before we go to either the Minister of Finance or the Parliament to really have those kinds of policies endorsed, what we try to do is have enough case to really make the case, have enough evidence for that. So that has been the case for the example I shared earlier, showing its impact on mortality, but also we try to include also the economic investment cases in those, in the economic case for the investment in addressing women's health issues and challenges. Sorry, cite few examples that I did. For example, the health insurance system that we are implementing is a community-based health insurance, which is for the informal sector currently, that largely is covers largest part of the population, which started small and then scaled up. But every time to scale up, we always try to generate the evidence. And of course, It had clear evidence that it was enhancing financial protection and reducing out-of-pocket expenditure, but it also had an additional benefit of empowering women by having that CBHI card where they are members. They, with different evaluations we did, they confirmed that now they don't have to wait for permission of their spouses to go get care or for themselves or their children, which is really not something you may quantify in terms of money, but it has a huge impact in terms of the health utilization and so on. And then we include those evidence also to push again when we are asking, because we recently asked that the federal government need to increase its contribution to the CBHI, and a lot of evidence need to be put there to convince the Ministry of Finance to add that money. And another good example is on menstrual hygiene, which is a key barrier for girls' education and health, but usually really a matter that's really disregarded. So we had to really advocate and work a lot with partners to generate the evidence and then work with the Ministry of Finance to again remove tax from the menstrual hygiene products, which became successful. So I think it requires both for us to be clear of what is needed and what should be done, have the evidence, but also really engage with the different stakeholders. And we didn't only work as a public sector, we work with civil societies and partners, and then collectively go to the other policymakers who have the power of deciding on the budgets and other interventions to convince them.
Thank you.
Thank you.
Thank you so much for sharing those tactics and experience on how.
It's not always easy as
I can imagine. Gisela, a woman member of parliament, which is the supreme law-making place in our countries. How do you get the laws and budgets approved with financial protection embedded in the needs, particular needs of women and girls embedded into those laws that are approved by Parliament? How did you maneuver in Parliament?
Well, it's not easy, because not always it's the same. Probably we have big laws, but these laws has not impact in our society because it's the law. It's not only the thing that you need, and if you want to make a real law, you have to think how the culture, how the society is going to accept this law and how we are going to work with this law. And probably it's not a magic fix to create a law. Passing a law, it's one thing, but ensuring that it's work in real life, it's the real challenge. We need laws that don't just sit on the books, and this is the most important thing that we have to think as parliamentarians. And we have to create law that push the systems to change. And for that, probably we have to think like laws which create incentives and enforce the controls that improve healthcare for everyone. Laws do not change paradigms overnight. You need to check, adjust them, and make sure they are already working to make the difference. And probably, in my opinion, a key aspect is work law with the society, with the nurses, the doctors, the lawmakers, the public and private sectors, because it's the only way that you can create more progress and you can create a law accepted by everyone. Because probably, I don't know how it is in other countries, but in my country, we can have many laws. For each disease, we have a law, but this law has not a real impact in the society. And before I was talking about C-sections, and in Argentina exists the humanized birth, but we have the 50%, and in the private sector, the 90% or 80% of C-births, C-sections are not the natural one. And this is because the women prefers the C-sections because it's about the culture of our country, and also because the system hasn't accepted the law, no? They don't work in the law. So sometimes we have to create this law working all together, and probably like laws that help us to think in the big issues and not in the particular one. Probably we have to create laws that focus on the fundamentals, for example, gender equality and non-discrimination in healthcare, but as a framework and not as a particular. So for that, we have to think in other idea of the law, and probably we have to create new mechanisms to create this kind of legal situation in our countries, because right now it's difficult to understand how to combine, for example, the law that we have and the necessity of the society.
Thank you.
Thank you.
Thank you for that. The laws are not adjusted to the needs of the people. So let's move to programming and implementation and then see how the policies and laws that you are telling us are not adapted to the needs are implemented in real life. I'm going now to move to Dr. Adipeju Adeniran, an experienced clinical and public health physician who is also the founder and national co-chair of Women in Global Health Nigeria. Thank you for joining us. And Taimur Khan Jagra, senior expert at Hakazus, former provincial minister of Pakhtunkhwa for Finance and Health in Pakistan. Starting with Dr. Adipeju Adeniran. I would like you to tell us what are the daily shortcomings that you see in your practice and your research when women seek health care.
Thank you very much, Magda. First, I'm going to talk about factors that affect healthcare in Nigeria overall. Then I will speak on how women as a gender are then affected. So that's twice, right? There are hurdles to access in healthcare in Nigeria. We have problems with infrastructure, facilities that can deliver full function of health services, lack of essential drugs and equipment, human resources, inadequate capacity. There is 1 to 9,083 people when you talk about physician to people ratio. And this inability to balance the human resources to provide health care has also affected women in a disproportionate way. So, as a citizen of Nigeria, women are plagued with issues like transport, distance to health facilities, and other bureaucracies. And then there's issues relating to protection of that access, protection of usage. Of course, most Nigerians are not protected from the cost. Out-of-pocket spending, from affecting household budgets by 10% to catastrophic financial impact of health because it's out-of-pocket spending. There are families that never recover from one member of the family having a significant health illness, and that is still present today. I'm then going to talk about, so these are present if you're a citizen in the first place, okay? Then I'm going to speak about, then if you're a female citizen, so that's twice. One of the most important things that will affect a woman with health services in Nigeria is her ability to reproduce. And that affects what she needs to be healthy. There is overwhelming evidence that if women access reproductive services, there are improvements to maternal and child health. It increases the well-being of individuals, families, and communities. But only about 1/5 of Nigerian women are using a modern form of contraceptives. And 23% said they had unmet needs for reproductive services. Over a quarter of childbearing women in Nigeria consider their last birth as a product of unwanted pregnancy. So a quarter said, the last time I gave birth, I wasn't planning to do that. All right, so apart from that, then we have a large number of births to adolescent girls. About 1/5 of adolescent girls in Nigeria have children. The pregnancy rate is 106 per 1,000. These consequences, these result in high-risk birth, intergenerational poverty. Because just like Princess child is never going to get out of the cycle that Princess is in. Because Princess was malnourished, that child is malnourished, Princess dropped out, Princess does not have access to funds to send that child to school, and that child, by being given birth to by an adolescent girl in Africa, has their generation predetermined. And those are some of the ways in which the poverty is entrenched. So targeting adolescent birth is one of the ways that we can address generational poverty. In lower to middle income countries, Nigeria is an example, but she could have just been talking about my country. So, how do we tackle the place of women in this system? We must address the social autonomy for women and girls. We address it and we entrench it. And how do we entrench social autonomy for women and girls in Nigeria, for instance? But like I said, I could be talking about anywhere. Education. We already know that is one of the major indicators of women empowerment, particularly secondary school education. You enhance the woman's literacy skills. It is a major factor in uptake of reproductive services and childcare, because a more educated woman is a woman that has the confidence to have health-seeking behavior, because the health services are better designed for people with education. Yeah. The nuts and bolts of that is that there are language and literacy barriers. I will expand. I am from Nigeria. I am Yoruba. I speak both English and Yoruba. When I go to a health facility, most of the information and the communication is in English and is in Yoruba. But even when it is translated into Yoruba, what people forget is I have to be able to read Yoruba. The fact that I can speak it is different from being able to read it. So, literacy and language are two levels of barriers. And in my personal practice, I go to health sectors, the communication is written in English, and then it's translated in 3 major languages, as if, because I speak the language, I can read the language. That's not true. I can, but reading script and being able to translate that is usually within formal literacy education. Whether that is in a school or under a tree, I have to be taught to read script for it to make sense. So translating from English to local language does not remove barriers. We have to target removing barriers to literacy and language, and not just language. That is some of the things that we see in practice. So, to be able to remove equity for women in the health system, we must entrench social autonomy. And education is very well linked to autonomy. And when we move that autonomy from one generation to the other, we rescue Princess, we rescue her child, and her child rescues their child. Thank you very much.
Thank you for those lessons on Yoruba and English and how we go about educating and empowering women to be able to take care of their own lives. Let me move to Timor. When you were provincial minister, you launched the UHC, correct me, I know I pronounced it wrong.
Sehat card.
Sehat?
Sehat card. Sehat stands for health. The longer name is Sehat Sahulat card, but it's known as a Sehat card.
Sehat.
Yeah.
This was a universal health insurance program covering essential medical services, surgeries, and hospitalization. Our audience would like to know, how did you go about it? Which challenges did you face? And maybe one or two successes also.
Yep.
We don't want to hear only about bad things.
Yeah. No, so the good news is that I think there are plenty of good things to tell about health insurance as a potential vehicle, not just for universal health coverage, but also, I believe, as someone who had never really worked closely with health before I took on the health ministry literally a week before COVID struck, as the ability of health insurance to really work as the central nervous system in a regime to transform health. Let me explain what I mean, because to tell you the challenges, let me tell you a little bit the story and the outcomes of the Sehat card or the health card. The belief with which it was launched, and interestingly, unlike most such programs that are launched in countries such as Pakistan, other developing countries either in Asia or Africa, this was designed by the political leadership of the country with our own money. Yes, the original intervention was sponsored by German aid to a very small segment of the population, but the impact that it had, it became one of those rare instances where what you learn in development theory is something that politicians pick up and interests align, and you grasp it with both hands and you actually implement it. So, very interestingly, it became from being the typical development partner initiative that covered people below the poverty line to literally covering everyone first in the province of Pakhtunkhwa. That's 40 million people. And then being picked up by then Prime Minister Imran Khan and covering almost all of Pakistan, covering all of Punjab, which is 130 million people. So our universal health insurance program till date, expanded literally over the last 2 or 3 years, covers 170 million people for inpatient and emergency services, and maybe, I think, the largest program of its kind in the world, if not certainly one of the largest. And maybe a credit of that goes to the failure of our family planning services, but that, I think, is a separate debate. I would also say, unequivocally, the most transformative social sector intervention in the history of Pakistan. And why not, right? When we talk of reforming health or achieving universal health coverage, Pakistan has a huge network of public sector hospitals, teaching hospitals, secondary hospitals, basic health units, maternity clinics, you name it. I actually counted, I think there's more than 10,000 public sector facilities. But like any other developing system, many of them failing. So if you really want to transform health, why not go for a disruptive intervention? And that's what health insurance turned out to be. And I think the results were beyond our wildest expectations. So I already said 170 million people covered. Over the last 3 years, over 10 million beneficiaries, 5 million a year. So the uptake is about 3%. The cost. And I think this is important. And this is important because one of my proudest moments was when I used to get calls from friends in the US saying, how did you do this in Pakistan when we fight elections on this in the US? But the cost is about $2 a head a year. And it was about 2% of our budget. It was about 10% of the health budget. And the only bold step we had to take was in the year we were going universal, was to find the 10% that we wanted to give to it as an additionality rather than, trying to cut off the health budget elsewhere. It was easier because I had the finance portfolio as well as the health portfolio. So as someone used to tell me, talking to the finance minister was easier than in many other situations. But once we had done it, I think the results were incredible. Some of you will have heard of Aga Khan University. It's the premium university in Pakistan and basically focuses on medicine. And they challenged me to hold a third-party evaluation. I said, do it. I'll give you all the data. The report is there on our government website. And once they are done, they were phenomenally excited about the results because it dealt with a lot of problems that you talked of. It wasn't about changing laws. It was about getting implementation on the ground. It was about fixing many of the failures of a public health system in one need, in the sense that it enabled us to get access to private sector hospitals, right? And gave people both choice as well as additional financing in the system. And the citizenry loved it. The satisfaction rate in multiple surveys was about 97%. And even though we made it universal, and there's some criticism about why the rich were benefiting from it, remember that in most low-income countries, rich is a relative term. I mean, my salary as a health minister, I used to be a McKinsey partner, so that's what allowed me to be a politician for 6 years. But my salary as a health minister was $600 a month, and that put me in the top 5% of earners in the country. Now, when I hear things like a catastrophic health cost can change the fate of families, it is absolutely true. If I'm in the top 5% of earners of the country at $600 a month, if I don't have a financial safety net, imagine just one member in my family getting sick, right? How do I cover that cost? You have to sell a house, you have to sell assets, etc. And this is why this was transformational. And I think it's an area that is largely ignored by development practice. I think now to get to the challenges, so I hope that's enough of the good news. But to get to the challenges, there were plenty. I mean, fascinatingly, the biggest challenge was convincing the insurance sector that this was possible to do. So we had an existing program and run by the State Life Insurance Company. And when we pitched the idea to them, they said it's impossible. They said hospitals will overrun. And I remember telling them, look, no one goes to a Pakistani hospital happily. They only go when they need to. Trust me, the hospitals will not overrun. We convinced them, and we rolled it out between November 20 and January 21 in 3 months for the first 40 million. The second challenge was constant resistance and political propaganda. But I figured out a lot of that was from the rent-seeking part of the health sector. So take, for example, a lot of medical professionals in Pakistan who employed in the public sector, because it's dysfunctional, will work in the private sector and create an arbitrage opportunity. This was killing that. And so There was a lot of propaganda about corruption, etc. But every time we did a third-party audit, yes, there were the odd hospital where there were more cesarean deliveries than there should be, but we know that's the norm everywhere, right? The biggest challenge was when our government changed, and the program had been in implementation for over a year at its universal scale. And the challenge was its success. It became attached to our government, and although we had actually put in legislation to mandate that it couldn't be changed, the incoming government tried to raise hell and high water to try and change it. And interestingly, I will tell you, it was not the legal protection that we put in that has saved it till now. It was the fact that we paid a lot of attention to detail, and that its credibility lay in public demand. That meant that every time they tried to push it back, they knew that public expectation had now been set to expect it, and it just couldn't be put back for political purposes. So it continues to stay. I think more than challenges, there are opportunities to design the entire health system around it, as we look at all other reform. And yes, just lastly, sorry, it has, in data and numbers, had a significant impact on addressing gender issues as well. A, in terms of reducing deliveries at home. B, in general, and I was just looking at the latest data this morning, there's been a 10 percentage point increase in terms of the use of women. In the early days of the program was 40%. Even without deliveries, it's 51% now. And the reason is because of its simplicity and universality.
Thank you.
It gives everyone the equal opportunity.
Thank you. Maybe let me just ask a follow-up question. Was the private sector involved?
It was. And it was both something that we had to show a lot of political leadership on to make sure it stayed involved. Because a lot of criticism that we faced was why money is going to the private sector. And apologies to sort of Indians in the room, but the argument I used to make, look, it's the private sector of Pakistan, it's not the private sector of India that we're funding, right? That we have a rivalry with. But what is interesting to me is, first, that in terms of the involvement of the private sector, it's been a win-win, because as when I would wear my finance minister hat on, what it enabled was a future opportunity to reduce CapEx spending, capital expenditure spending in the health sector, because it meant not every hospital had to be a public sector hospital. The second thing it did was, as the private sector was involved, right, it actually started to create choice and competition. And I found that of the 200 odd empaneled public sector hospitals, as more money flowed to public sector hospitals, for the first time in an inertia-driven system, they started to compete with the private sector. In the end, I'd just say, it's not just the private sector in terms of hospitals that benefited. Over time, I saw increased excitement in the insurance industry. And over time, I also got feedback from the pharmaceutical industry.
Thank you.
That it helped them.
Thank you. It is important to involve the private sector to expand the services, but be aware of the side effects that might sometimes not be so positive.
Indeed.
Thank you. Thank you so much. Back to Adifejo in Nigeria. Which lessons could be learned from Nigeria and applied in other countries in terms of promoting equity in healthcare delivery? Maybe one or two we can take back home, we take to Ethiopia, Guinea-Bissau.
So what I have is a statement of problem and a controversial statement. When we address equity in healthcare delivery in Nigeria, I'm going to use the case of reproductive health services and female autonomy, and how all of that works out for financial protection and UHC. So the first question I have is that what is the explicit measure of autonomy of women in the healthcare sector? We don't agree on what it means. We draw boundaries around it, but we don't really agree on what it means. There are studies that report female autonomy, but they have not been consistent in their terminologies. Some researchers have elaborated autonomy as having the following 3 dimensions: economic autonomy, physical or movement autonomy, and decision-making autonomy. And they're really difficult to separate, because if you have the money, you can move and you can make decisions, okay? However, the thing that we don't pay enough attention to is that we have not really defined what sexual autonomy for women is. And very few have constructed explicit measures for sexual autonomy. But this sexual autonomy is very well linked to reproductive health and reproductive health services. And while we haven't done this, there are clear links between sexual autonomy, reproductive health services usage, and other indices like maternal and child health, under 5 health. So it has too many consequences in my mind for us not to spend time looking at what sexual autonomy and how it relates to reproductive health services is. So, from a research point of view, I want to define reproductive autonomy as the power to decide about and control on matters associated with contraceptive use, pregnancy, and childbearing. My words, the addition, is for the end user. In other words, the person with the uterus has to be able to decide about and control matters associated with contraceptive use, pregnancy, and childbearing. Research links the influence of this sexual autonomy on the use of modern contraceptives. So, we know that the contraceptives are there. They exist. It's not enough for access. Using the words of Luke, the nuts and bolts, the problem is not that they're not there. The problem is, where is the power to be able to use them, and how is sexual reproduction linked to that? Sexual autonomy linked to that, okay? Because if the woman does not have the sexual autonomy, she's unlikely to use the contraceptive method. And I want to speak to one of a researcher that I really, really admire, Dr. Ushma. I'm sure I'm pronouncing her name wrong. I am sorry in advance. Dr. Ushma Upadhyaya. And yes, she developed the reproductive autonomy scale, in which we measure in women how the freedom from coercion, partner communication, and decision-making with women when it comes to sexual reproductive autonomy. And when we have this well-defined, then we will be able to say we have access right. This is my controversial statement.
Thank you.
I was just getting to my controversial statement. I'm sorry, I'm running out of time. And when we speak about reproductive health as being synonymous with family planning, I know that we intend for partner involvement, but when we use family planning as synonymous with reproductive health, we are dissolving autonomy. What this means is that the end user, the person with the uterus, has less power and is less likely to use contraceptives. We don't discuss dental rights for people with teeth, but we discuss reproductive rights for people with uterus. They somehow have to toggle for it. But we don't do this in teeth.
Quite controversial. Thank you very much. Thank you. We should come back to that conversation about teeth and uterus. I would like to thank the panelists. We have come to a close of this discussion here at the table. We have very little time for a couple of questions from our public. I will start here, then here, and then there. 3 questions, if possible. Tell your name quickly and then to whom you are addressing your question. That corner there. Then the other one here.
Hello, good afternoon. Please, very nice discussion. My name is Tunteya. I'm a clinician from Ghana. So my question is directed to Dr. Adeniran. So my question is that since you said, what you said at the end is that sexual reproductive rights is not is discussed with people with a uterus. I just want to know what Nigeria is doing at this level, like in policy making, to ensure that sexual and reproductive health and rights are discussed, and if you have a comprehensive sexual education in your country. Thank you.
Thank you. We come here.
Hi, my name is Saad. I'm a Pakistani Canadian physician currently based in London. My question is to Dr. Adeniran and Mr. Chakra. You mentioned about reproductive autonomy, which is very important. How do you inculcate and integrate reproductive autonomy in a culturally sensitive country like Pakistan, where there's a lot of cultural barriers to discussing reproductive autonomy, and is financial hardship linked to it? Thank you.
Thank you. Then we have a hand at the back there. Unfortunately, we can't not take any more questions because we have reached the time limit.
Okay, thank you very much, moderator and the panelists. My name is Israel Adekunle Balogun. I'm a medical doctor by training. I'm a public health physician, currently a PhD student. My question is actually to everybody on the panel. You've talked about addressing financial hardship when it comes to advancing health equality. But I don't know, in your various countries and your context, have you taken time to include the needs of persons with disabilities, including women, girls, and children with disabilities? And do you have data to back it up? Thank you.
Thank you. Very quickly, starting from here to the end, if you could add one thing you'll do when you go back home to change the situation, but very quickly,
Yes.
2 seconds.
Okay. Nigeria is very well supported by partners to provide standalone adolescent reproductive health services. That's one of the things that it's doing right. And that's kind of keeping with separating it from family planning, because family planning obviously will be an unmet place for an adolescent girl, for instance, to access the services.
Thank you. Thank you. Thank you. Quickly, Pakistan. Your question was to Pakistan?
Yep.
Yes, because she has had a chance. Yes.
Yeah, so look, all I would say is if we can get our primary health system to function, right, I think we underestimate the ability of women to access what they need to locally, even in culturally sensitive environments.
Thank you. That was short and sweet. Thank you very much. And then people with disabilities, who would like to take that question? Dr. Leah.
Okay, it was also for you. But, well, that's definitely, when we talk about equity, it's every aspect of equity we need to address. And usually we lack a lot of data in terms of disability, but that is central to achieving UHC as part of meeting the equity gap in terms of how we deliver care. Thank you.
Thank you very much. We have come to the end of this conversation. I know that there are so many questions you would have loved to ask. Health is a human right. There are so many barriers to access to quality health care without hindrances, particularly financial ones, and particularly the fact that being a woman, an adolescent, or a girl, you have additional barriers to access health care. We need to continue pushing this agenda in order for us to overcome the inequities that society brings to us. Thank you so much for coming. and joining us for this conversation. I'm really thankful to the panelists and to our co-host, the GFF. Thank you. Thank you very much to you all.